This new life polymer is supposed to be working longer, as some of the you have seen some of the slides shown by Dr. Martin on how to improve the duration of this working. There's everything without handheld touching, or everything robotic mediated is done by this. I congratulate this new format, and we're fortunate that Dr. Leon is also associated with this company. This is next slide. I have to control here. Okay. So as we all know, we all believe in introducing the new things, innovations, and new innovations happen, keeping the necessity, what is required for the patient. That's the beauty. So now we all know that TAVR is extended even to low-risk patients, and what we now are not able to do it in younger is basically because the prosthetic valve degeneration happens. That's why we are not able to recommend this to young patients. But suppose if this can be further worked on, and the same valve which is initially being tried on surgery and can be extended into the percutaneous valve therapies also, which is likely to happen in future, then probably that could improve patient outcomes and increase even the younger patients getting into this therapy. And that will further, if it works closer, longer, it could reduce healthcare options, costs, and broader treatment options too. So let us see now how this TRIA Mitral Valve Life Polymer program is redefining the heart valve therapy treatment. So we have 4 sets of talks, or 3 sets of talks initially. Dr. Martin, B.Leon, then our surgeons also will share their experience. With this few words of introduction, I request Professor Dr. Martin B.Leon to deliver his talk in this. Thank you.
Thank you very much, Srinivas. Certainly, this is a great example of how we can work together. Also, how India can lead, and also how we can work together not just as structuralists, but as the entire cardiovascular community, which is imaging, surgeons, structuralists, cardiologists, and that's why this project for me is a very exciting project. I've been involved trying to work with the company Foldax to be able to understand how to better use this new powerful material in cardiovascular disease for the past 5 years. So I told you earlier that I believe that aortic stenosis, as an example, as a case study, is a lifelong journey, but there are other valvular lesions, frankly, where younger people are being treated earlier and with the opportunity to have a durable material that would be a lifelong material would have enormous implications. And certainly, when we talk about this lifelong journey, it means that we've got to be very selective about how we manage patients before they get their ultimate treatment, and in particular, how we deal with this issue of bioprosthetic valve durability, since this is really the only material other than mechanical valves that is currently being used to treat patients with valvular heart disease. We have to learn how to define this concept of durability. I think we've gone a long way to be able to do that with some of the consensus documents that we've developed over the past 10 years. But we still see in the United States, we still see around the world that either surgical or transcatheter valves over time are going to develop this disease called structural valve deterioration. And in the future, the only way to be able to provide better technologies for our patients at lower cost and with less morbidity is to really work hard on developing newer leaflet materials. Because this concept of bioprosthetic valve failure, which we see in the United States for both surgical and transcatheter valves, as shown here, has become an epidemic. And we need to find ways to be able to change the epidemic. The specific mechanisms of tissue failure mechanisms are very briefly and schematically shown here. It's a complex process, and certainly there's degradation of the matrix, calcium deposition, immune responses, which result in structural deterioration of the leaflets, fibrosis and calcification of the leaflets themselves and at their insertion points, and even damage to the tissue. So these are known mechanisms which need to be adjusted if we're going to have more durable valves. Many people are working in material science to develop new materials, but we really think that a true polymer valve may be the best solution to provide a durable future for patients with valvular heart disease. Now, this is not so easy. Everybody talks about polymers for valves, but the history is not very positive. It began in the 1950s with many, many new materials. Then over the past 20, 25 years, there have been, again, almost 10 new polymer types that have not gone well. So polymer valve technology has been attempted for a long time, but this history of mechanical degeneration, polymer degeneration, and thrombotic complications is very real and needs to be understood, and we need to develop materials that are not going to be prone to these failure modes. So the Life polymer, which is a new polymer being used in the TRIA valve or the Foldax valve, tries to address the limitations of tissue valves and polymer valves, knowing that polymers will facilitate computational valve design, which is one of the ways we think this may be a better valve material. The development criteria for the Life polymer involve physical property specifications, biostability, creep resistance, blood compatibility, non-calcification, other biocompatible features, and most importantly, manufacturing stability that can manage supply chains. The particular materials used are not unique, but the way that they are mixed and developed is entirely unique. At least part of this copolymer development has been going on for almost 2 decades now with a biostable siloxane polyurethane blend that has been used in pacing leads. And importantly, the chemical modification allows synthesis of this Life polymer with specific mechanical properties that don't compromise the oxidative stability. Computer modeling plays a large role, and the computer modeling is analyzed with a full cardiac cycle, specifically for aortic and mitral designs, optimized for hydrodynamic efficiency and to reduce localized stress. And full sensitivity of these computer models is performed on every valve size. I think you can see at 23 millimeter TRIA on the top that the accelerated opening force and the opening profile is quite different than and superior to comparable tissue-related valves. So everything has been computationally designed, including the polymer properties, the optimal hemodynamics, and trying to reduce the stress profile. You're seeing a surgical valve as shown here with the PEEK stent, the Life polymer, which is almost invisible, it's almost transparent, which encapsulates the PEEK stent, and in this case, the PTFE sewing ring. In valve hemodynamic testing, the TRIA Mitral valve is equivalent to the Edwards-Perry valve, size adjusted. This blend of polyurethane and siloxane, as we've said, has been used clinically in patients, so biocompatibility has been nicely demonstrated based upon the pacing leads that have been developed over time. This again is the TRIA mitral surgical valve that you'll see more of in a few moments, and 2 versions of transcatheter valves, the first being self-expanding, and the second, more recently, a balloon expandable version using the TRIA polymer material without sutures to be able to develop a full polymer transcatheter valve that potentially could be used certainly in the aortic and ultimately in the mitral position. The second unique aspect of this is the robotic manufacturing, and I just learned that there is a robotic manufacturing facility for developing these valves in Surat, which obviously is very well known for its medical device companies and its high technology. This particular robot, which is now in Salt Lake City building all these valves, allows you to have very precise, reproducible processes with almost no human handling or interactions. It's not labor intensive, so there is no sewing of the leaflets. These small, efficient robots can be developed anywhere, and the fact that there is an equivalent robot being used now in India is very exciting to us. You're going to see the results of a 67-patient, 8-center study across India that was conducted meticulously and to the highest standards, at least as good as any FDA study that we've seen in the United States. I'm not going to go through inclusion and exclusion criteria, but we'll simply mention that the echo mean gradients and the EOAs by valve size are very stable at least over the first 30 days in the first series of valves that have been developed. Again, more data will be shown to you, but ultimately the final study of this will be presented when we have more data with complete analyses by the physician scientists who've been responsible. And here again to develop some curiosity, this is a version of the transcatheter valve that ultimately could be a TAVR system in the future using this same material, and we're very excited to see that being used at one point over the next year or two. So what is the future of bioprosthetic valve technology? We believe it's a polymer technology, and in this case, the TRIA valve. We are hoping to be able to achieve for our patients one valve for life, starting in the mitral position and then growing in different directions depending upon the results. It's very important to acknowledge the scientists, the physicians, the founders who've been so involved in this project. So you're seeing in the top row many of the people on the stage who are real thought leaders and have enrolled the patients and have the most direct clinical experience with these devices, collaborating with a whole series of physician scientists in the United States, including cardiac surgeons, one of my close friends, Isaac George, in the center, and other interventional cardiologists like Steve Yakubov and Brian Wisenant, all people who really have a great interest in developing new valve technology. So we are very excited to be part of this global collaboration team led by our India colleagues. Thank you very much.
Thank you, sir, for bringing us to the exciting aspect of valves working longer and valves being made only by the robots, and to share the 30-day clinical experience with us, as mentioned by sir. We have none other than Dr. Kaushal Pandey. This is the beauty of Indian surgeons. He's a senior consultant cardiac surgeon in Hinduja Hospital. But more than that, you name any surgeon, they have, to their credit, performing about 30,000 plus cardiac surgeries. That is the strength of our country, actually, where we have huge number of patients. Unfortunately, all of them get huge experience, and yes, so many patients got benefited by him. He's also credited with his expertise in valve repairs, ischemic mitral surgeries, and tricuspid. And as we are fortunate to have him here, and he will discuss and present the 30-day results from the Indian clinical trial study, the TRIA Mitral Surgical Valve Program. Dr. Kaushal Pandey, please.
It's my privilege to be speaking to all of you, and especially my talk follows Martin B.Leon, a living legend in this particular field. So I'm here to present a landmark study on the use of polymer valve. So this study is to report the clinical and echocardiographic outcomes of the TRIA valve at 30 days. However, majority of our patients have actually completed 1 year, and the study has been submitted for DCGI approval. I am here only to present the first 30-day outcomes. So this study was carried out at 8 different centers spread across India, and the map shows it all. 2 of my colleagues are here on the stage who will be making the subsequent presentations. Basically, we have selected very safe cases so as to remove other adverse factors which may affect mortality. And the whole idea was to give the best shot for this particular valve. There have been at least 3 other attempts, clinical attempts, at the use of polymer valve. However, this is the first study which actually completed its full duration, and I must say we're very, very pleased with the initial results. So basically, the primary endpoints at 1 year are safety. So we are going to report all-cause deaths, thromboembolic events, major hemorrhage, major paravalvular leak, endocarditis, structural valve deterioration, and of course, valve-related reoperations and any hemolysis. And of course, this part of the talk is going to assess how effective the valve is, how good the gradients are, and how is the effective orifice area maintained over the follow-up period. All these patients have been put on oral anticoagulant, vitamin K antagonist for a period of 12 months. The target INR was 2 to 2.5. Approximately 50% of the patients stayed in this range in the first 30 days. And to my mind, maintaining patients in the correct range in the first 30 days is actually very vital. We have not yet finalized our strategy about long-term anticoagulation of these patients. To summarize the patient demographics, the average age of this study, 67 patients, is only 42. 64% of the patients were females, and of these, over 60% were in the childbearing age group. And that's a very important statement to make, because in Asia and in large parts of Africa, rheumatic heart disease continues to plague our population, and managing a female patient who is very young in the childbearing age group, we just don't have the right valve at present. 42% of the patients in this study also had chronic atrial fibrillation. So as I said earlier, the study was, the patients were enrolled by a careful selection, and all safe patients were only used. So most of them had completely normal heart function. Majority of the patients had mixed lesion of mitral stenosis and mitral regurgitation. The average mitral valve orifice area was 0.9, and the average LA size was documented at 5.2. We also had this unique CT imaging wherein valve sizes were imposed on the CT image of the patient. This is also the first time we recommended that if the valve was going to cause 50% or more obstruction of the LVOT, then we had to undersize the valve. So this meant that every patient was screened very properly preoperatively to ensure there is no LVOT obstruction going to happen in the postoperative period. Almost 80% of the valves used in this study were of the size 25-27, which is quite typical or characteristic of practice in this part of the country. Operative time was usual average of 3 to 3.5 hours. Most patients had an aortic cross-clamp time of 60 to 80 minutes and a bypass time of 90 to 110 minutes. Now what about the 30-day safety outcomes? We had one death, and this death was due to rupture of the left ventricular posterior wall, which actually happened 24 hours after surgery when the patient started to drain. The patient did give us an opportunity of going back to the theater, but somehow, though the repair was very effective, but the patient went into low cardiac output and succumbed. There was one more adverse effect that was a stroke, but the patient recovered completely within 24 hours. So all-causes mortality for the series of 67 patients is 1.4%. As I said, bleeding was that embolic stroke, was that hemorrhagic stroke, but the patient fully recovered. When we compare our numbers with similar studies, we are at par with the best in the world. To summarize, if you see the preoperative baseline gradient, mean gradient was 9.5, which at 30-day follow-up is 4.3. And if you see the effective orifice area, average for the study, pre-op was 0.9, and at the 30-day follow-up, it is 1.7. If you see, we've also managed to document improvement in the cardiac output. These are some images of this valve, but I'm not showing the video because my colleague, Dr.Anil Jain, is going to elaborate on the echocardiographic findings of this particular device. And as I said, the mean gradient was 9.7 for the average for the study, which is at 4.3, and the effective orifice area 1.7, which is as good as it can get. The same numbers if you compare with a similar study from MITRIS, where the effective orifice area at 30-day average was only 1.2, and the gradient was of course 4. The red bar is the bar which is pre-op data. The blue one is at the immediate, at the time of surgery, and the yellow bar is at 30-day. And you can see that both effective orifice area and the gradient are well maintained over the 30-day period. Now that we also have a data at 6 months and 1 year, the numbers are maintained. So we are very encouraged by performance of this valve, and I certainly enjoyed being part of this beautifully conducted study. Thank you very much.
Thank you for the encouraging initial study results. Now we have Dr. Anil Jain presenting us some of the more details of younger patients with echocardiography studies. As you know, he is a famous cardiac surgeon in another city of Ahmedabad. After performing a lot of surgeries, now also turned to entrepreneur. He started an Epic Hospital in Ahmedabad. Fortunate to have him here. Over to you, sir, for your presentation on this interesting aspects of this younger patients in rheumatic heart disease. Dr. Anil Jain.
We all know that treating valvular heart disease is very difficult, and still the final solution is eluding us. An ideal valve would be one that lasts forever, does not need anticoagulation, and patient can carry out his normal activities without any other valve related problem. That valve still eludes us, but I'm sure Foldex valve or the TRIA valve is a little path forward in this particular direction. I'm going to talk of a young female, 27 years old, who had rheumatic heart disease and was treated using the Foldex with the TRIA valve. This patient had a ejection fraction that was normal. The gradient of the valve was 28/12 when she was admitted for surgery, and a mitral valve area was just 0.4 centimeters square. She had a normal coronary angio. We did angiograms for all patients that came in for study. And as you can see on the echo, there is a huge left atrium. The mitral valve is extremely diseased, and there is mitral stenosis with mitral regurgitation. She also had ongoing atrial fibrillation. All patients taken in the studies had a left atrial appendage ligation, and we did try to do a maze procedure to try to get them back into sinus rhythm after surgery. This lady had a conventional open surgery. We replaced her, excised her mitral valve and replaced it with a 27 sized Foldex valve. And just as we came of bypass, the mitral valve gradient was 5/3. So what I'm trying to stress is we have seen single digit gradients across the mitral valve. Dr. B.Leon had shown the valve. The computerized image shows an absolutely wonderful, fully opening valve when it is seen on an echocardiogram. As you can see, even in the 3D image, you can hardly make out that there are leaflets in the valve. The valve is literally invisible to sound images. The effective orifice area was around 1.7 just as we came of bypass. These are some images post-operatively which we have seen. You can see the valve is there. It is opening and closing, but the valve, can I have a pointer there somehow so I can show, is there a way I can get the pointer going? It's coming. So you can see here that there is this valve here, and you can hardly see any valve. There's no valve seen there. And if you look at the next image, the second image, you see an absolutely quadrangular, nice parallel flow of blood. So that means the valve leaflets open literally completely and allow an excellent flow of blood across the mitral prosthesis. So that is something wonderful. Again, here you can see this is a 12-month follow-up where you can see the way the blood goes through the prosthesis. So there is no obstruction, the leaflets open completely, and you can hardly see any of these leaflets as they open or they close. The only thing that is visible is the tips of the leaflets where they actually fold for coaptation. That is the only area where you can see this area around here. You can see a little bit movement of the valve leaflets. CT scans were done for these patients, and you can see no collection around the leaflet. There is no strut visible, nothing is visible, and it's a pretty decent appearing valve at the end of 12 months. These are some 3D images that I've got, and this image is from the ventricular side where you can see the valve leaflets are moving a little bit. The valve leaflets are not visible, and there is no thrombus, nothing. Clean, absolutely clean valve leaflet there. Here you can see this is from the mitral side, the left atrium side. The suture knots are seen, the housing is seen, but the leaflets are as good as transparent. You don't see anything there. And this is the wonder of this valve. The valve leaflets look good and clean. The valve opens beautifully. There is a good flow, and there is hardly any gradient across this valve. So this is actually the wonder of this valve. Look at this CT image. You can see only the struts. Other than that, nothing is seen. except the struts as the image goes up and down. We did CT for all of these patients on follow-up, and the only image we could see was the peak stent that was visible during the CT image. Other than that, we saw nothing in these particular valves. As you see, this is the same patient's follow-up over time, and this patient came with a very small mitral valve area, very high gradient, and once the valve was replaced over follow-up, her gradient has stuck to only 3-4 millimeters. That's hardly any gradient, no gradient. It is like this valve has no gradient across it. It opens up beautifully, the flow is excellent, everything looks good and fine. And look at the mitral valve area. It sticks, it stays. There is no reduction in mitral valve area over time. The leaflets, the polymer is so wonderful that it opens smoothly and closes smoothly. And because of that, the mitral valve area continues to be the same over time. So I would conclude by saying that this would be a wonderful replacement to the available valves. Tissue valves have their problem, mechanical valves have their problem, but the Foldex is a polymer valve. The structure of this valve is more or less like a tissue valve. Hence, there are not likely to be any acute problems in young patients. Even if there is a coagulation or a thrombotic issue, surgeons will get time to go in and do something for the patient before the patient crashes. So it is going to be a boon for younger patients coming in for surgery. Of course, all patients, future also, as all of you are cardiologists, maybe someday you will be able to do a valve-in-valve into these valves, which you cannot do for the currently available mechanical valves. So that adds some extra work for the cardiologist too. The performance of this valve is so far very encouraging, and the one-year outcomes have been very good. The valve gradients, the valve areas are really sticking to what we had expected it to be. This valve will definitely present a unique opportunity for the population in time to come, and I'm sure as the endpoints and the results come up, it will be a wonderful valve to replace from mechanical and tissue valves. Thank you very much for your kind hearing.
Thank you, sir, for that interesting presentation regarding the case. Another aspect which we feel is the porcine, bovine, no animal. Nowadays we are all conservative of the animal. That aspect is also not there. It's all created in the lab, and that will be also a good thing. And you said the cardiologist can put one more valve in it, but probably if it works longer, that may not be needed also. We wish that it works so long, so it will be one valve per patient per lifetime. So we wish that will happen, it will come near future. And then now in the last, I request Dr. Prasada to come and share why India should be chosen for advancing patients of such therapy for rheumatic heart disease. My pleasure to be chairing this dais with Dr. Sir. We were students waiting for his opportunity to meet him before. He's Padma Shri, and he has a lot of credits. He was ex-director of Nizam's, and he has done a lot of new innovative procedures, and now he heads a corporate hospital. Over to you, sir.
As you know, every sixth person in the world is from India. Unfortunately, we are not that much in cardiac surgery. However, it is progressing satisfactorily. Still, when compared to the United States and some of the advanced countries, our numbers are small. 250,000, around 250,000 operations in a year for a country with this much of population is not something which is correct. Now, we are also unfortunately leading in the number of patients with rheumatic heart disease. About 40% of the patients in the world suffering from rheumatic heart disease are from India. This is not something which we are not very happy. The rest of the people are, most of them in Africa and spread out in the rest of the world. Then, while the degenerative heart disease, degenerative valvular disease is the commonest valvular disease in the developed countries, India still has the rheumatic heart disease as the primary heart disease in these patients, that too rheumatic mitral valve disease. And in this mitral valve disease patients, rheumatic heart disease patients in young females in the childbearing age. This is something which is unique for this country and then the sub-Saharan population. In the last 45 years when we started the valve therapy in India, more than 45 years, we thought about various valves. Still the answers are not there. In the long back when in 89-90, we did the study in Nizam's Institute of Medical Sciences. Some of my colleagues are still there, Dr. Raju, and then some of the people, Dr. Rajgopal Raju was there in the meeting. We did the study to find out the closed mitral valvotomy, open mitral valvotomy, and the balloon mitral valvotomy was started. Since that time, we are trying to locate a valve which can replace the normal valve. We have not found the answer. There are commercially available valves. We had problems with the durability. In fact, when we started the mitral valve replacements in India, whatever the problems we had, our prayer to God was to have once in a lifetime valve without anticoagulation with good hemodynamics. We have not found the answers until now. Until recently, we have this mitral valve produced by this Life Polymer, which is an Australian research product taken over by the United States and being produced at Salt Lake City. I am also very happy to report that we have been privileged to go and visit this production facility. We worked with the team, Foldex United States team, and there is one Dr. Isaac from the surgical group, Martin Leon from the medical group, who have pioneered this study from the United States point of view, and several surgeons, eight teams, several surgeons, including my colleagues Anil, Jain and Kaushal Pandey. We have completed the study and the analysis is going on. Hopefully in few months, we should be able to complete 1 year, and at the end of 1 year, we are going to have the presentation, and then hopefully the Drug Control General of India is going to give the permission, which is going to be launched. Now, this is very important for the Asian, that is Indian population, and also sub-Saharan population, because of the young Indian population, childbearing population, mothers who are lactating, who are having the children, they can go back to their families, lead an almost normal life. This is the thing which we are predicting. And because of this new development that has taken place, we are likely going to have this valve, which is going to be a once in a lifetime operation for the young lactating mothers. Then, while we are saying that our valve is likely to be good, we also need to have long-term studies, which is likely to be there. We are comparing ourselves with the other biological valve, which are likely to fail around at the present at about 15 years of age. That failure for that 15 years is for the population, which is degenerative valvular heart disease in the advanced countries, like degenerative aortic valve disease and degenerative mitral valve disease. And in this population, the degeneration of the tissue walls are quite fast. That is why this polymer valve, which is going to be introduced in India soon, hopefully very soon in a few months' time, is going to be a landmark achievement in the heart valve therapy and structural heart disease. Hopefully, it may not require replacement. Even if it is requiring replacement, with the technology that is being developed in the Foldex valve, there may be a replacement with the percutaneous heart valve through the valve. With this, I thank Foldex for giving us the opportunity, Dr. Srinivas Kumar and the TCT team for having us to have her here. I thank everybody.